Hello, my name is Matthew McCurdy, and I'm a third-year internal medicine resident from the University of Kentucky College of Medicine Bowling Green campus. I'd just like to share with you an interesting case of a 39-year-old female with severe gestational hypertriglyceridemia, which resulted in pancreatitis, as well as its identification and management, just for the fact that it's a very rare condition, with the fact there's not a whole lot of good guidelines out there based on how to manage something like this. We found this case to be interesting because it was not something that was very common in our hospital. We know pancreatitis is pretty common overall, but fortunately in pancreatitis in pregnancy it's very uncommon. Only about 1 out of every 10,000 pregnancies will experience something like that. As etiologies go, we know severe hypertriglyceridemia is pretty uncommon to cause pancreatitis. Only about 1 to 4% of cases annually are from that, versus gallstone in about 70% of cases, versus alcohol in about 25% of cases. Gestational dyslipidemia does occur as a natural physiologic change. Usually about 12 to 14 weeks you get an increase in estrogen levels, which by the third trimester of pregnancy can result in triglyceride levels up to 3 times the upper limits of normal, which can be physiologic. For our patient, she was a 39-year-old female with medical history significant for mixed hyperlipidemia that was well controlled by diet, which was confirmed by laboratory testing prior to her pregnancy, as well as gestational 7, pair 5, with 2 previous spontaneous abortions, both occurring before 20 weeks of gestation. She would present initially to our labor and delivery department with an 8-hour history of severe mid-epigastric pain that radiated to the lumbar spine and lower quadrants of the abdomen, as well as intractable nausea and vomiting that was non-bilious and non-bloody. Initial diagnostic workup, including ultrasonography, was unremarkable, with the baby having good fetal vital signs. However, our laboratory testing would eventually reveal a significantly elevated lipase of about 7,900, with triglyceride levels being greater than 4,000, which was new to her as her previous triglyceride level was less than 200. We did see that this was the most likely etiology, so we started her on aggressive intravenous therapy with lactated ringers, as well as an IV insulin drip to help mitigate the triglyceride levels and hopefully improve her pancreatitis. However, we did decide to ship her to a higher level of care because our NICU support was not there for preterm labor and possible delivery of that baby. At the outside facility, she did undergo plasmapheresis with concomitant insulin therapy and fluid therapy with significant improvement of her hypertriglyceridemia and resolution of pancreatitis. As far as management of pancreatitis in pregnancy, especially hypertriglyceridemia induced, we know that insulin is a very safe therapy. It's usually recommended as probably our first line therapy, with intravenous fluid therapy being there with it. As far as plasmapheresis is concerned, though, there's a number of case reports out there that have shown that it's been effective in reducing triglyceride levels without deleterious side effects to the patient or fetus. It's recommended that we have close monitoring of those triglyceride levels, and therapy be continued until the levels are below 500 milligrams per deciliter. And usually at that point, if the patient's going to go back up, then we would say that they need to start some oral therapy as well. If the patient were to be at 37 weeks of gestation or more, then we would say that usually delivery of the baby would be advocated as long as there's no other contraindication in doing so. In closing, I just want to say a couple of things. Due to the low number of cases of this type of condition, there's no strict guidelines out there, so knowing that IV insulin and plasmapheresis are both safe and effective at lowering triglyceride levels, that's important to remember, and that pharmacotherapy is usually indicated in pregnancy if the triglyceride levels remain greater than 500. I'd like to thank you for your time, and thank you for listening to this brief presentation. Now, 3 minutes are not a whole lot of time. If you have any questions or any other things you'd like to discuss, please reach out to me, and I'd be happy to do a little bit of discussion with you. Thank you, and I appreciate your time.